It is now time for the last session of Build 3.0. Please join me in welcoming our chairpersons on stage, Dr. Rajesh Dharamsi, Dr. Prashant Butch, Dr. Ashish Sethi, Dr. Tejas Modi, Dr. Ruchit Patel, and Dr. Banka. I request the chairpersons to introduce the speaker.
Good afternoon. Uh, Whether we treat the patient of hepatitis B, all of them with a TAF, or whether we treat only those who are symptomatic, whether we treat portal with thrombosis or not, at the end of the day, cirrhotics will land up with a hepatocellular carcinoma. So what can be more apt than having the last lecture on hepatocellular carcinoma? So I welcome Dr. Vogel. He'll be telling us about recent advances in the management of HCC.
Yeah, thank you very much for the kind introduction, and thank you for staying here to the end of this meeting. And I would like to discuss with you the recent advances we have made in the treatment of HCC. This is the latest update of the ESMO guideline, and actually the new update has almost been accepted by Annals of Oncology, and hopefully we can publish and you can get it in a few weeks or months. But what we have already mentioned in the last, or what we have shown in the last update, is that we do have now a lot of opportunities for systemic therapies, as you can see on the right-hand side. In the old days, we had nothing, then sorafenib became available, but today we have a lot of IO combinations, TKIs, and we can actually apply sequential therapy. And in early stages, of course, it's of utmost importance to identify the best local treatment. Here we have a lot of options, from surgery, resection, intra-arterial therapies, to radiation. And also, and this is what we are seeing, the systemic therapies are moving to earlier lines of treatment. When we look at the outcome in the most recent phase 3 studies, you can see that we have made progress. When only sorafenib was available, the median overall survival of our patients in advanced disease was very low, with less than 12 months. With the introduction of second-line therapies, we observed that also in those patients that were treated with sorafenib in the clinical trials, in the control arm, median overall survival improved, and we observed an increase to 15 months. Same observation actually for lenvatinib. In the REFLECT study, the survival was only 13 months when compared to sorafenib, and in the two recent trials, when lenvatinib was used in the control arm, we achieved a median overall survival of 20 months. And now with the IO-based combinations, we are getting close to 2 years, which is clearly better than before, but of course also still a lot of room for improvement. So let's briefly go through the most recent IO-based combinations that we can use today in clinical practice. The first combination that was approved was atezolizumab and bevacizumab based on the IMbrave 150 study. Sorafenib was used in the control arm, and as you know, all efficacy endpoints were clearly and significantly improved with atezo-bev. Response rate for the first time up to 30%, which we have not observed before, and also progression-free survival and overall survival were clearly improved. These patients, of course, also developed side effects, not only IO-related side effects, but also side effects related to the VEGF antagonism, so hypertension, proteinuria. But overall, the side effect profile was clearly better tolerable for the patient, and quality of life metrics were improved compared to sorafenib. And with that, when we look at the toxicity and efficacy, Sorafenib was no longer a standard in patients, and here we had the recommendation for atezolizumab and bevacizumab in most national and international guidelines. And this concept of combining a checkpoint inhibitor with a VEGF-directed therapy was also supported by the CARIS study, which is interesting because we have seen that some studies which combined TKI with checkpoint inhibitor were negative, like the COSMIC study or the first LEAP study. But here in the CARIS study, camrelizumab and rivoceranib were combined and compared to sorafenib. And similar to the IMRAVE study, we observed a clearly improvement of all efficacy endpoints, including response rate, progression-free survival, overall survival. But again, side effects are something that needs to be considered. And here, really, the majority of patients developed side effects more than grade 3, which were, again, mainly related to the VEGF component of the TKI. And many patients developed hypertension, proteinuria, or transaminases increase. So it is better tolerable, I think, compared to sorafenib, but still these patients most likely require close management. And we cannot only combine TKIs or VEGF-directed agents with checkpoint inhibitors. We have also now 2 studies with 2 checkpoint inhibitors, dual checkpoint blockade. The first study that was published was the Himalaya study. Here, initially a 4-arm study, durvalumab and tremelimumab were compared to sorafenib. One arm was closed, and in the end we had 2 arms, single treatment with durvalumab, and in the next experimental arm, a single dose of tremelimumab was added and compared to sorafenib. Both arms were positive. We observed a non-inferiority for durvalumab and superiority for STRIDE. Durva and tremelimumab was shown. Also, response rate was clearly improved up to 20% with STRIDE. When we look at the side effects, they are now only immune-related, of course, because we only have 2 checkpoint inhibitors in the treatment. The number of side effects were increased when we add tremelimumab, so not only efficacy, but also toxicity were increased, and more patients required steroid. It's increased from 10 to 20%. The latest study that was published was the CheckMate 90W. Here, again, same principle, dual checkpoint blockade, but in this study, more CTLA-4 were used, so patients received ipilimumab up to 4 doses. Again, efficacy endpoints were improved, and actually in this study we observed the highest response rate ever for systemic therapy in HCC, and up to 40% of patients developed a response, which were sometimes very durable, as you can see on the right-hand side. Overall survival was improved compared to here in this study mainly lenvatinib, but we have to acknowledge that in both arms the median overall survival was quite decent, 20 months with lenvatinib and almost 24 months with nivo-ipi. One problem with this combination are again the toxicity profile, and actually in the study there were 12 treatment-related deaths with nivo-ipi, which equals to 4%, which is twice as high as we observed in other clinical trials in HCC. 20% of patients had to stop treatment because of side effects, and 30% of patients required steroids. So here, probably we also need to closely monitor these patients and manage these side effects well. And we need to decide upfront whether we think that our patients can tolerate this steroid treatment in addition to the cancer and the chronic liver disease. This is an interesting analysis or comparison that has been done by Professor Kulu and published last year in liver cancer. So here, he combined and overlaid the Kaplan-Meier survival curves of the most recent phase 3 studies. And what you can see here for the control arms, that we have very consistent survival data in the control arm. With sorafenib, we can now expect around 14 to 15 month median overall survival. And for lenvatinib, we can expect a survival of 19 to 20 months. When we now look to the experimental arms, it's a little bit busy, but I think there are 2 important points. One is, if you look at the initial curves, shape of the curves, you can see that in those trials in which only immunotherapy was used, we have an early decline, which was not observed in patients that received an additional VEGF drug or lenvatinib. So probably here we have more responders in the initial phase on treatment. However, when we look at the tail of the curve, we do see the benefit of these pure IO regimens, and when we add more CTLA-4, we get more long-term survivors. And this is also very evident in the most recent updated data from the Himalaya study with STRIDE. In the first 12, 15 months, the curves were very close together and only separated after 3 to 4 months. However, when we then look at the tail of the curve, which is here a little bit not really shown nicely, but what you can see, I hope, is that at the tail of the curves are really separating more, and we clearly have more long-term survivors. And now we can actually report survival data of 4 or 5 years, which was unprecedented and has never been shown before. And an additional point from this updated analysis was what is the impact of disease control? And usually we are talking about partial response, complete response, which is of course very important. But I think here we also nicely showed that disease control is important and has really prognostic implementation. So when you look at the Kaplan-Meier curves, those patients that are not responding to the treatment have a poor outcome, no matter what we are doing, sorafenib or STRIDE. On the other hand, when we achieve disease control with the first CT after 3 months, you can see that the curves are separating nicely and they are more in favor of STRIDE, and we have more, again, long-term survivors with STRIDE compared to sorafenib. So I think these data highlight very nicely that basically the quality of the response with the immune checkpoint inhibitor is probably better compared to those the response we achieve with tyrosine kinase inhibitor. And this is actually a cartoon summarizing these findings. So when we use tyrosine kinase inhibitors or bevacizumab, we usually, most likely, there are more patients that will respond to the treatment, and we do see this initial benefit of the curves, which we have seen specifically in the CheckMate 90W study. On the other hand, the immunotherapy kicks in later, and then it's really difficult to use PFS or median overall survival because the tail of the curve is important, and we do see more long-term survivors. And I think this is what we want to achieve in the treatment of HCC, that we get more patients to cure and long-term survival. And we can actually cure patients with systemic therapy, which is also something really new. And this is a summary of a real-world cohort from our colleagues from Austria. And they summarized data from almost 4,000 patients. And as you can see here, we can expect in around 4, and in CheckMate 90W, 7% of patients complete responses. And now we can report recurrence-free survival, which we usually only report after resection, right? And when you look at the curves, they are very much very similar to what we observe after resection. They are indeed patients that are cured and that do not recur with their tumor. And from a practical point, what we observed is then if we continue with the treatment for more than 6 months after achieving the complete response, we do get a better response compared to patients in which we had to stop treatment earlier. So once you reach a complete response, I would recommend to treat at least 6 months and better a year to achieve and maintain this long-term response. So when we look at the treatment today, we do have a lot of options, which is good and bad. Good because we can decide, bad because we need to make decisions, right? And the question is, how should we decide among these 6 approved and available options? One very simple question is, can we use an immune checkpoint inhibitor, yes or no? And if not, I would think the preferred treatment is lenvatinib. If you can use a checkpoint inhibitor, we do have at least 4 options which I think are meaningful, and we need to decide, do we only want to go with checkpoint inhibitors, so durvalumab or nivo-epi, or do we want to use an VEGF component, either bevacizumab approved or rivastigmine not yet approved in HCC? And of course, we can apply sequential therapy, and actually, as I have shown you in the beginning, we should apply sequential therapy. With that alone, we can improve survival of our patients. So how can we now decide on the treatment? And what we are doing then, and we always say we should not do it, is we do cross-trial comparison. This has a lot of caveats, of course, because the the studies recruited in different countries and centers. There were different in- and exclusion criteria, and we really need to be careful. When we look at the overall survival data, I think they are very close together. We are now achieving 20 to 24 months, and it's probably hard to say that one drug is really superior or one combination is superior to another combination. In terms of progression-free survival, I think it's not frequently used to make decisions. We may want to acknowledge that the longest progression PFS we have seen so far was actually with lenvatinib and not with the IO-based combination. In addition to PFS and overall survival, we can also look at responses. Of course, partial response, complete response is important, specifically when we think about downsizing, downstaging. But disease control is also important because when we have patients with aggressive tumors, we do not want them progress them right away on the first-line treatment, or when we apply bridging before transplant, we would like to have long-lasting disease control, and we don't want to lose patient on systemic therapy. And with the new treatments, we are now achieving disease control rates of more than 80%, which is clearly better than before. With sorafenib, we had a disease control of only around 50%. So taking all of this together, I think probably the survival data are more important in the palliative setting when we really want to improve overall survival, while the response and disease control rates are mainly more important in earlier settings. And I think, and I mentioned before, these systemic therapies are now moving to earlier stages of HCC, and specifically in liver-limited BCLCB, when we want to downsize and downstage, I think these response rates are really important, and we can most likely bring more patients to potentially curative treatment today as we could in the past. Okay, when we now switch again and look back to the palliative patients, we are having so many options today. We need to make wise decisions, right? And we need to look closely at our patients and also consider comorbidities. And of course, when we add bevacizumab, as you all know, we increase the bleeding risk, which is important. And our patients do not only bleed from varices. In addition, and I mentioned, bevacizumab has a high VEGF activity, and we induce hypertension in many of these patients. So cardiovascular comorbidities are also getting increasingly more important, and more of our patients actually have a metabolic syndrome with sometimes uncontrolled hypertension. And of course, if patients have underlying autoimmune diseases, we need to be cautious with dual checkpoint inhibitors because we may induce flares of their other underlying diseases. So when we now look at the side effect profile, which is in addition to the efficacy, of course, important, all of these combinations induce a couple of side effects. I mentioned the grade 5 side effects. So we have a higher rate of treatment-related death with nivo-ipi. So we need to be, I think, more careful with these more frail patients. And importantly, most of these patients died because of liver-related complications. So specifically in patients with more advanced disease, IB2, we probably need to be cautious. And the other factor I mentioned already before are the steroid use. When we use more activation, more CTLA-4, we need to use more steroids, 10% for monotherapies, 20% for STRIDE, and 30% if we add more CTLA-4 in the CheckMate 90W study. And then I mentioned before the metabolic syndrome and the potential problems treating hypertension. When we look at the side effects, and this is a very detailed analysis and you cannot read it, I just want to focus on hypertension and proteinuria, which are clearly VEGF related. You can see this occurs far more often when we have BEV as a treatment partner. So this is something we may want to consider when we decide on our treatment in the first-line setting, also for HCC patients. Bleeding risk is very clear. You know, these patients have a high risk of bleeding. And when we look at the data from the clinical trials, even in these highly selected patient population, and that received actually an endoscopy before starting of treatment, 7% of patients develop bleedings. which was clearly less with, for example, stride or nivo-epi. So when you have patients at risk for bleeding, you need to think about BEV and whether you can really accept the risk or not. And again, this is a clinical trial patient population, and our real-world patients are certainly more prone to bleedings than these patients. We had a lot of discussions on whether the underlying liver disease has an impact on outcome, and we have seen very interesting preclinical data suggesting that a fatty liver in mice may actually prevent the efficacy of immunotherapy. However, we are not treating mice, at least generally not, but patients. And the question is, can we really extrapolate these data from mice to humans? And I think we can't. This is a summary on the right-hand side that Tim Meyer and myself put together. And as you can see, both for hepatitis B and hepatitis C, the viral diseases, but also the non-viral diseases, the benefit of the treatment is always in favor for the immunotherapies. And when you specifically look at the data for stride, on the left lower part, you can see that in the hepatitis B cohort, we do see a good benefit. In the non-viral cohort, we do see a similar benefit. And maybe here in this study, hepatitis C patients benefited less, but I think also we see less and less hepatitis C patients. And I think with these post hoc analysis, we need to be cautious anyway. But I think my take-home message here is that we do not really have convincing evidence to think that at this point in time, patients with fatty liver disease would not benefit from immune checkpoint inhibitors, and you should not withhold immunotherapy from these patients. However, even when the underlying liver disease is not important, the liver cirrhosis is important. And I mean, we have heard a lot about liver cirrhosis before, and it's very clear that the liver cirrhosis alone has a significant impact on the survival of our patients. Usually we use the TRIPUA scoring system. In clinical trials, we use more and more the IB score. And I think the IB score is more helpful to distinguish the patients with well-preserved liver function and more advanced or more impaired liver function in the TRIPUA cohort. And it's not only important in terms of the prognosis of these patients, independent of their cancer, but also maybe for the efficacy of our treatment. So here you can see the data from the Himalaya study. And you can see there's this clear prognostic impact. And again, remember, these are all TRIPUA patients, yeah? And those with IB score 2 had a far shorter survival compared to those with IB1. So IB1 survived twice as long as IB2. But what you can also see here is that the curves are separating in both cohorts. So the efficacy of stride is independent of the liver cirrhosis and liver function. However, this is actually not the same when we look at the IMbrave 150 data. And you can clearly acknowledge that the benefit that we have seen in this trial with atezo-bev comes from the IB1 cohort. So for patients with a more impaired liver function, we do not see superiority anymore for atezo-bev compared to sorafenib. Hazard ratio around 1 compared to a hazard ratio of 0.5 in the IB1 cohort. Again, something you may want to consider when you have patients with a more impaired liver function, that the efficacy of stride is clearly maintained in the IB2 cohort, something we did not observe with atezo-bev. And not only that, I think when you look at the most recent real-world data for atezo-bev, which is still the most frequently used treatment, no question. But what we are realizing is that the survival data are not as good as in the clinical trial. And this is a study from Germany where we looked at, compared in a retrospective cohort, lenvatinib with atezo-bev. And you can see with the 13-month survival was clearly shorter in the real-world data set compared to IMbrave. And one reason for that is, and this is what we observe more and more in clinical practice, when we treat patients with more advanced liver cirrhosis, they are at risk of decompensation. And I think this is something we need to acknowledge more when we treat our patients, not only in clinical trials, but also in clinical practice. And that's why I think it's so important that hepatologists need to be involved in the treatment of HCC patients. They are at risk of decompensation, and we know that if they decompensate, outcome is really poor. It's even far worse compared to those that have tumor progression. So monitoring for liver decompensation is important, and these patients then need to be treated accordingly. And the risk of decompensation and not restarting treatment is higher with atezobev than with lenvatinib or STRIDE. So in the last part of my talk, I want to briefly touch on the liver-limited population. And I think this is a very interesting population because, first of all, it is very heterogeneous. We have patients with a single tumor, we have patients with multiple tumors, big tumors, small tumors, invasive tumors. And with this heterogeneity, we also have a lot of treatments that we can potentially employ. And we need to be here, we need to discuss these patients, I think, in the tumor board to decide what is the best treatment. And it comes from transplant, resection, intraarterial therapies, radiation, to systemic therapies. And we really need to make wise decisions here. And in the past, this was clearly dominated by local therapies, yeah, but more specifically in those patients with more advanced liver limit disease, we do have now more options. And these are basically the combinations of local and systemic therapies. And we have seen the first positive trials in this context. And most of these trials have been conducted with a combination of IO-based combinations and TACE. And the first study that was published was the EMERALD-1 study. Here, durvalumab and bevacizumab both combined with TACE. And what we observed, and this was the primary endpoint, is significantly improved longer progression-free survival compared to TACE alone. And also the response rate was clearly higher in those that were treated with a combination compared to those that were only treated with TACE alone. Overall survival data have not yet been published. And these data were actually also confirmed in the LEAP study. Here, lenva pembro were combined with TACE. And again, when you look at the right side, right upper panel, you can see the response rate are clearly increased with the combinations by 50% to 50% by RECIST 1.1, and even higher than 70% by mRECIST. And again, this higher response rate translated in a longer progression-free survival. However, overall survival was not significantly improved, and at best there was a slight trend. So we need to dissect these data very carefully and really need to decide how we should proceed in clinical practice, even already today. And I think since we do not see a clear survival benefit, we probably should not treat all our patients now with liver-limited disease with the combination, without survival data. However, when we think about downsizing, downstaging, the response rate is, I think, very, very appealing. And I think in intermediate stage, we really should not only think in one direction anymore, but in two directions. Yeah, and Professor Kudo phrased this term of curative conversion. And of course, with more advanced BCLCB stage, the likelihood is less prevalent. But I think we have the opportunity today. And not only in clinical trials, but also in clinical practice, we really need to decide where do we start, what is the intent of our treatment, and what is our endpoint. And if we have patients that are resectable or transplantable, there's a discussion, do we need any systemic therapy at all? If we can go directly to transplant or resection, most likely not. We don't have really evidence that neoadjuvant treatment would be advantage. If we have to wait, it may be good for bridging and we can avoid progression. If we have these intermediate patients that are not resectable, not transplantable, we do have now really extremely good options for downsizing and downstaging. And our endpoint here clearly is to offer curative treatment. And last but not least, we have the unresectable, untransplantable patients. And here we would first consider palliative treatment. However, palliative treatment does not mean that we cannot achieve deep, partial, or complete responses. So again, coming back to the term of curative conversion, we need to reassess these patients and see whether they either develop a complete response just with the immunotherapy, or whether they get a deep partial response and maybe candidates for local therapies. And again, here our intent would be to offer more patients potentially curative treatments. And I think if we do this in clinical practice, we can really make a really big step forward for the care of our patients. And last but not least, IO before liver transplant is not a contraindication anymore. We have very good data highlighting and showing, and you can see here up to 75% of patients were downstage with immunotherapy, and many of these patients, up to 40%, were brought to liver transplant. And we do not have to worry too much about rejections and graft loss. This occurred rarely if we have a washout period after the immunotherapy, and we have here summarized our thoughts in this snapshot in Journal of Hepatology just a couple of weeks ago. So immunotherapy before transplant is definitely an option, and we should evaluate our patients for liver transplant if they respond nicely to the immunotherapy. So this is my last slide, and I think this is where we are. Today, we do have a lot of options. We can not only decide among a lot of different local therapies, but also a lot of different systemic therapies. And we need to consider all these factors, patient-related factors, age, comorbidities that I have mentioned, tumor-related factors. Do we have liver-limited disease, vascular infiltration, liver-related factors, how advanced is the liver cirrhosis, and how good is the liver function? And then we need to decide what is our treatment goal, our aim, intent of treatment. And with that, I think we can make wise decisions for the treatment of our patients. And with that, I'm looking forward to any questions. Thank you.
If you want any questions. Okay, so if there are no questions, then we conclude the session. Thank you, sir.
Thank you, Professor Vogel and chairpersons. We now move on to the last session of the day, the case-based discussion, which will be moderated by Dr. Mridul Dharur. Our panelists for this session will be Dr. Anil Anand, Dr. Ashok Chaudhary, and Dr. Nipun Verma.
Good afternoon, everyone. And I think I am the only one standing between you all and the lunch, so I will try to make it quick. This is just a case-based discussion on adverse events of immunotherapy. Now that we have started using immunotherapy more commonly, we'll be seeing a lot of side effects. So we'll try to make it quick. Case 1, 56-year-old male, known case of diabetes and hypertension, presented in October 2023 with the symptoms of 10 kg weight loss over a period of 2 to 3 months and a right upper quadrant pain. Investigated, revealed to have NASH-related cirrhosis and a multicentric HCC with entire right lobe being involved, as well as had a PVTT VP4, the RPV enhancing thrombus extending into main portal vein and left portal vein. Endoscopy did reveal grade 1 to 2 arisis. Alpha fetoprotein was 3.8. He was started on lenvatinib 8 mg at that point of time, but the DCP went on increasing from 1836 to 5857. And at this point of time, with the progressive disease, he was advised atezolizumab and bevacizumab. After third cycle, on the weight loss persisted, we evaluated further, and he was found to have a TSH of 0.008, suggestive of significant hyperthyroidism. So the first question to Ashok: how do we manage post-immunotherapy hyperthyroidism? This is the case for you.
Yeah. Thank you. This is a typical scenario of having hyperthyroidism, and it happens around 6% cases in case of particularly A and B therapy. And overall, this expense around 8 to 25%. So the treatment for hyperthyroidism does not differ much whether he is having a liver disease or not liver disease. Only thing that how we can anticipate. So in that, the ESMO guideline recently they come up that they will do TSS or thyroid function test at least monthly. That is only thing you can detect early. Or you are getting unexpected weight loss, tachycardia, restless behavioral changes in your patient, then you should think that way. That is suspicion. And third, if you think of treatment, it will be same. You give beta blockers. You can give also the drugs we normally give, propylthyroxine or methimazole, carbimazole also. And staging as you're going to delay is there. So hyperthyroidism treatment is nearly same as far as SCC. with therapy or without therapy is concerned. Only thing that we have to make a protocol of follow-up when to test them. That is now as per the ESMO every monthly. And then second, if you're treating these patients, and then we need to monitor, because most of these patients will end up becoming hypothyroid later. Because now median time to develop hypothyroid is average 1.3 months, and around 3 months, 3.4 months, they develop hypothyroid. So initially there is a hypothyroid phase, destruction of the parenchyma because of the immunity, then lands up in hypothyroidism. So you have to manage.
Would you consider radioactive iodine if you diagnose someone as a hyperthyroidism in such a case?
Yeah. So in terms of arterial vivacity, it is not a contradiction to give if you are able to control your thyroid related symptoms with therapies as far as beta blocker for the rate control or propyl thyroxine or anything, as far as the delay is not happening, then you can continue and you can give the therapies. But in fact, I have no experience on this for treating a hyperthyroid. We have seen around 3-4 cases of a hypothyroid. So
Hypothyroidism.
that is why limited number of cases, and practical experience is zero. So only from the literature evidence I am suggesting. But I don't think hyperthyroid is easily manageable disease. You should continue the immunotherapy. That is my suggestion. I think my panelists can suggest.
So it would not be a contraindication to continue with the immunotherapy. Anyone has any other comments? Sir?
I completely agree with Professor Ashok. The only thing is, depending upon the severity of presentation, one would hold immunotherapy. If it is a grade 3 or 4 adverse event according to grading criteria, then would like to hold and see the follow-up of patients.
Sure. Just continuing with this case, so he also had dryness of mouth after first cycle itself, and after 8 cycles noticed significant skin excoriations with pus oozing from the scrotum. This was May 2024. He got hospitalized. These are the images of the scrotum. So significant skin excoriations, pus. These lesions almost persisted for 3 months. So, Nipun, for you, how would you manage skin and mucosal adverse events? I understand oral stomatitis and everything is very common. It was common with TKIs also, but it is common along with immunotherapy. And now with this kind of a skin effects.
So, well, with immunotherapy, there have been reports of, dermatitis, pruritus, bullous region, bullous dermatosis. So, these are the most common adverse event per se of immunotherapy. The more we add up the immunotherapeutic agents, the combinations, the more likelihood of the development of these complications. On an average, these complications range about 15 to 20% in several series and randomized controlled trials. According to the grading criteria by clinical trials, CTCAE grading, these can be graded based on grade 1, 2, 3, 4, and 5, which is mild, moderate, severe, very severe, or life-threatening, and death. But it is arbitrary classification. So there is a new concept of body surface area involvement and quality of life worsening, and how much is the impairment of daily activities with the adverse events, skin adverse events. And the ASCO has come up with the grading system. Grade 1 is less than 10% involvement. 10 to 30% involvement is grade 2. More than 30% body surface area involvement is grade 3. Grade 4 is life-threatening, requiring hospital admission. And 5 is death. So coming back to this patient had severe, and most of these adverse events usually happen within first 4 cycles of, and there has been a data to suggest those who develop these adverse events, they are more likely to respond as well to immunotherapy. So, but coming back to this patient would have had dermatitis and pruritus. He scratched probably and then developed a secondary infection
Yes.
on top of it. So, as they say, for any adverse events during immunotherapy, you should rule out other cutaneous causes of rash, which might be in our setup. It can be some scabies, it can be any other autoimmune phenomena which is pre-existing in a patient. So that excluded, given that this patient has a rash because of immunotherapy, grade 3 rash requiring hospital admission, we would hold immunotherapy. Then starting with topical emollients and antihistaminics, we would give antibiotics, topical and systemic, to control the infection. And then if required, we can add oral prednisolone 0.5 to 1 mg depending upon the residua after treating infection. And then if the grade of this rash comes down to less than 10% of the body surface area, we can reinitiate with a careful supervision. We initiate the immunotherapy with close supervision of. So, but these are the commonest adverse events. 15 to 20%. Grade 3, 4 and grade 3 and 4, if adverse events are rare, they are about 1 to 4% in several series. But depends, when we add the number of immunotherapeutic agents, it increases the risk of adverse.
Yeah, so this patient, actually the skin lesions persisted for almost 3 months. We had a surgeon involved, local application of antibiotics, antibiotic creams and oral antibiotics. And at some point of time when we reinitiated, we were wondering whether to restart, whether to modify the immunotherapy, whether to give only atezolizumab or use both A and B again once the lesions have healed. So any thoughts on that? Whether you want to modify the immunotherapy or continue the same?
So it comes back to the patient. It has to be patient-centric approach. We discuss pros and cons with the patient and the availability of the drugs in a given setup and the cost, obviously. So given if there is an atezo-bev, you have now tremi and durva. You can always consider other form of therapies, but it has to be patient-centric and it has to be shared decision with the patient and family.
Thank you. We'll just go to the next case. So this was a 68-year-old male, known diabetic with a BPH, his past history of stroke, known MESLD, and presented in April 2023 with itching and jaundice, history of CAM intake. At that time, he was also HIV IgM positive, managed conservatively initially. Imaging also showed a 9 by 8.7, segment 8 by 4A lesion and a RP with thrombus. The LFT, which were deranged, bilirubin was 6.8, enzymes were on a higher side, ALP, GGT 554 and 232, but INR was maintained. PEUCA was 69,000, AFP was 2768. Endoscopy did reveal 3 small esophageal varices. We allowed the HIV and the CAM related liver injury to settle down. Meanwhile, he also had an episode of spontaneous HE. Did receive lenvatinib, could not tolerate higher doses and underwent 1 cycle of tear. This was the liver lesion on the imaging. Subsequent MRI did show disease progression and received 1 cycle of atezolizumab and bevacizumab. Started developing cough and prolonged fever. Did not settle down with normal antibiotics, got an X-ray done which was showing some opacities bilaterally, and then underwent a PET-CT and a HR imaging which revealed significant ground glass opacities in both the lungs. We did a BAL. The BAL was positive for both PCP, PCR as well as beta-D glucan. So this question, any of you can take. What would be the risks of typical and atypical infections post-immunotherapy and the way forward? Any of you if you can take.
You can see immunotherapy is not going to suppress the immunology of the cirrhosis much. So therefore they have the nearly same infection profile most of the times as the cirrhosis likely to develop. And as far as this person has been there, he's having cirrhosis, long-term disease follow-ups. So therefore he has a chest infection, and I think it is positive for pneumocystis carinii.
Yes.
But PCP, and I think I have not gone in literature to show that atelivevasi has any relation prediction for the PCP. And now he is already PCP, he needs to be treated for the PCP, and PCP prophylaxis as such needed lifelong, being a patient of immunocompromised. So now he needs treatment followed by prophylaxis, and this is not a serious disease to consider stoppage of therapy. So immunotherapy can be continued, PCP to be treated, and then he needs a prophylaxis for the long term. That I can say.
Yeah, so we did give him the standard treatment for PCP with high dose steroids, and once the symptoms came under control, we gave him bacterium prophylaxis for PCP, and subsequently he did receive immunotherapy. He unfortunately progressed further, and we had to go on to the second line and the third line drugs. It's almost 2 years since his first diagnosis, and he's still with us. The initial liver disease was not bad. It was only the liver biopsy showed F2, F3 fibrosis. So the liver was otherwise compensated, but he had this big tumor. So you would say that patient is not going to get immunosuppressed because of immunotherapy. So the risks of infection would be higher or not really?
I don't think so, because it is, if you think of A and B, that is rather activating the immune system. It's not immunosuppression.
Okay, thank you. Yeah. So this is the case 3. 48-year-old male presented first in August 2024 with intermittent fever of 2 months duration, weight loss 5 to 6 kgs. HBV related CLD, multicentric HCC, significantly high AFP and PEUCA, and MRI showed fairly large like a segment 6 and segment 7 lesion, 11 by 8.6 and another 3.5 by 4.6 lesion. The enhancing tumor in the portal in the hepatic vein also reaching almost up to the ostium, and there was satellite nodules. Considering an unresectable multicentric HCC, he MELD 8, CTP A6, BCLCC. He again was advised A plus B. Post first cycle, within a week, he started having persistent fever. We did all sorts of infection workup, which was negative. The fever did not respond to anything. So this is for Professor Anand. How would you manage post immunotherapy inflammatory fever and any of the related symptoms, sir?
Can you show me the case this
Yes,
thing
sir.
again? Fever in any situation as an isolated presentation is a very challenging thing.
Yeah.
And in this patient, I see that there is an intermittent fever even prior to giving immunotherapy.
Yes, sir.
And this point was discussed yesterday by Dr. Neeraj Saraf. And he mentioned that one has to think of various form of infections or drug fever in this situation. Even in HCC, about 10 to 15% people can have fever. But I think you want me to discuss basically the persistent fever that appeared after giving immunotherapy.
So he initially definitely had fever, but like over the last couple of weeks, he never had fever. And post immunotherapy, when we gave the first cycle of immunotherapy, he started developing fever again.
Persistent fever now.
Yes, sir.
So this is basically what you want me to discuss.
Yes, sir.
So this can also be because of infections
Yeah.
that can be present earlier and may have become more aggravated, or it can be a drug fever also. And the one drug fever that I'll especially like to discuss is a febrile neutropenia.
Yeah.
The risk of neutropenia after immunotherapy is very small. Actually, it's less than about 1% or so.
Yes, sir.
And but it does occur. It's not that it does not occur, and one has to look for that. In this case, they have not mentioned the TLC this patient had, so I can't really consider that. Apart from that, these patients can also be having infection, which is underlying a viral or a bacterial infection. Apart from that, if immunotherapy-related syndromes of fever you have to consider, there are three basic syndromes that one must consider. One is a pathogen-derived cytokinemia. As you know, most of the fever is because of surge in the cytokines like interleukin-1, 6, and TNF-alpha and interferon gamma. Some people consider interleukin-2 and 8 also part of the same group. But this surge can occur because of the pathogens. And the commonest pathogen that becomes manifest at this stage is tuberculosis. The incidence of tuberculosis is about 35 times higher than in general population in people who receive immunotherapy. So that is one situation. The second situation is what they call as cytokine release syndrome. There is a surge in cytokine circulating after all immunotherapies that have been given. In this case also, atezolizumab has been given, and there is an increase in immunotherapy induced cytokine release syndrome. This usually comes from because of immune activation leading to tumor-associated macrophages releasing the cytokines. A more severe form of the same thing is called HLH, which has recently been reviewed in NEJM, and the patient may present with hemophagocytic lymphocytosis. The third syndrome is it may be a part of organ-specific immune damage. Although the fever appears first in these cases, the other manifestations can follow later on. For example, a patient may develop pneumonitis later on, or a colitis later on, or a hepatitis later on. As far as the management is concerned, in a mild case, we treat them with low dose of steroids.
Yeah.
In a moderately severe case where the fever is very high and the patient requires hospitalization, he will require high dose steroids. If that does not control the situation, we may have to give interleukin-6 and blockers like tocilizumab can be given. And in the more severe cases, which are life-threatening, one may have to try plasmapheresis.
Okay. So this patient, we did all the infection workup, including the cultures, PET scan, they were all negative. He was on antibiotics for almost 4-5 days and still the fever did not suspect. So after ruling out everything, he did not have febrile neutropenia or any of the other features of HLH. So finally we thought this was the inflammatory fever. He received steroids, low dose steroids. We use dexamethasone commonly for this kind of post-inflammatory fever, and he responded within 24 to 48 hours of starting the dexamethasone. And for another 48 hours, we observed him, then we were able to discharge him. He was in house. This is the last case. So 68-year-old female, diabetic, hypertensive, past history of supraventricular tachycardia, HCV-related CLD, previously treated with soft Velpa, relapsed, now on soft Decla, and presented in December 2023 with new onset ascites. So we investigated for decompensation, and the sonography did reveal a left lobe SOL with a portal vein thrombosis, around 6.9 by 4.1 centimeter tumor, thrombus or tumor, and the distal left portal vein had a tumor thrombus. So it was segment the same, the unilateral where the tumor was, there was a thrombus. UJS just showed grade 1 to 2 varices. DCP was 1241. The other parameters and the labs are written on the right. And she also received 1 cycle of A plus B. Post this immunotherapy, a week later, she got admitted with significant hyperkalemia, AKI, creatinine of 2 now, and oliguria and acidosis. In hospitalization, she had significant persistent abdominal pain after almost a couple of days, and we got an evaluation done in terms of a contrast imaging, which now showed that there was an extensive thrombosis of the splenomesenteric confluence and a complete thrombosis of the superior mesenteric vein and some of its tributaries. So there had been extension of the tumor, extension of the thrombus, which was away from the main, from the left portal vein, and she had rising lactate. So again, any of you, if you can take, we know post immunotherapy, bleeding is common, in especially with the bevacizumab in terms of variceal bleeding and all. But how common is thrombotic episode? Do you feel this is related to immunotherapy, the thrombosis extension?
Well, I guess as you said, the bleeding episodes are much commoner with bevacizumab and anti-VEGF therapies, but in this patient, as we can see, there is a progression of thrombosis, and this is leading to bowel ischemia in given patient and rising lactate. So given this scenario, I think this is might be a progression of disease per se on immunotherapy rather than an immunotherapy complication. But there may be difference of opinion, and Dr. Ashok would like to say, but I would like to withhold and treat as per the bowel ischemia and the guidelines for the same, IV, enoxaparin, and stopping the immunotherapy and admitting the patient in ICU.
Yeah, agree. In this case, I think 2 scenarios. One is albumin is normal 3.5 with ascites. So that means it's acute portal vein thrombus most likely. But I don't think the pain
So
was
the
there.
initial, the sonography and the CT scan before the starting of immunotherapy did not reveal involvement of the main portal vein. It was only the distal left portal vein which was involved. So main portal vein was otherwise clear.
But that was tumor thrombus or non-tumor thrombus?
It was a tumor thrombus, yes.
Tumor
Only the
thrombus.
left portal vein. The main portal vein and the right portal vein was completely uninvolved. And still she had an ascites.
Yeah. So, and then second scenario is a hyperprogressor. We called a hyperprogressor of SCC when immunotherapy started. So they worsen condition very rapidly in terms of liver failure, coagulopathy, both way. It can be prothrombotic or the hypocoagulous state. So in your case, we don't know because tumor thrombus, it can progress so fast to develop, but that can be picked in the FDG. So are you able to get any tumor thrombus uptake when this SMB is involved? The SMB involvement is tumoral or non-tumoral?
That was non-tumoral thrombus.
So that's why it is most likely the immunotherapy related aggravation of the coagulation cascade, and it's a we call it as a hyperprogressors. So these people are hyperprogressor have a very poor outcome when you give immunotherapy. So at any cost, we have to stop the immunotherapy. That is one, and then you have to manage for the decompensation. That.
Yeah, sure. So take-home message, Professor Anand.
I think Mridul has presented 4 cases where immunotherapy was given and patient developed certain complications. And from this, the take-home points would be, I think, today every physician must be aware of these complications because immunotherapy is being given not only for HCC but for large number of tumors. And therefore, a patient may have received immunotherapy earlier and may present with one of the complications to any physician, not only gastroenterologist or a hepatologist. An important thing to remember is that these complications can appear months after the immunotherapy has been stopped. So therefore, everybody has to be aware of these. The second point that I like to mention is when the patient comes, first you have to decide whether it is related to an infection, a complication of tumor, or it is related to immunotherapy. And once you have decided that it is related to immunotherapy, you must grade it as Dr. Nipun has mentioned, grade 2, grade 3, grade 4. Depending on what grade it is, the management of these patients would differ. And it will require either the steroids will be required, or TNF blocker or something else is required. This is beautifully classified in NCCN guidelines, which can be consulted at any time. And management should be depending on the severity. Anything else you like to say?
Thank you, sir. Thank you. So I will. So as we wrap up our Build 3.0 meeting as a part of APASL STC, I would just like to give a vote of thanks. I would like to extend our heartfelt gratitude to everyone who has made this event a success. First of all, Dr. Akash, he has been the brains behind this all build program. So I would like to thank him for all the conceptualizations and the executing the entire event. I would like to thank my co-consultants, Dr. Mihir, Dr. Amit Gupte, Dr. Mayur. Amit has spent sleepless nights. A very special thanks, Amit, for making this thing happen. I would like to thank our entire department. I would like to thank all the dignitaries, all the international faculty, national faculty who made it possible to come over here and spend the last 3 days and imparting all the knowledge that has been with them. I would like to thank the M.I.C.E, the event organizers, for beautifully executing the entire thing, which went quite smoothly. So we are not really much worried about the the logistics parts and everything. It has just happened. We just had to make the scientific program. So yes, I would like to thank once again everyone, and hopefully seeing you all with a much bigger and a better Build 4.0. Thanks once again, everyone.